Good morning and good afternoon, everyone, depending where you are in the country. Welcome to today's webinar with the Accountable Care Learning Collaborative. This is John Pullman. I'm the Executive Director of the Accountable Care Learning Collaborative, and we're excited to have you today. Our topic is the status of Medicaid ACOs and their projected future. My colleague at Leavitt Partners, Cristal, will be moderating with Q&A as well at the end of the webinar. We're really excited about today's presentation and the guests we'll have. Just a couple housekeeping items. If you've joined through the Zoom application on your computer or phone, if you can only go by phone, you won't see our slides, and we have great slides. We'll send them out after the meeting that you can download, so don't worry about that. We will have time for questions that Cristal will moderate. There is in the Zoom application a module in which you can submit those questions. We'll get to as many as we can. We've also received some by email, and we'll answer what we can here. And if we don't get to them all, we can do some responses afterwards. Just on the overall agenda, let me just give a couple updates here real quick on the ACLC. One, we do have our Save the Date ACLC member meeting October 23rd and 24th. The work groups will be getting together in person as well as a plenary session, and we're excited about things coming together for that. And the work group meetings are the third Tuesday of the month, so this next one is on June 19th. We do them all on the same day. If you have not signed up for a work group yet, we really hope you will. They're hitting some great topics right now. They've actually just reset and started some new discussion items. These are ranging from finances, talking about how to communicate organizational strategy. HIT is talking about how to do an assessment. The care delivery, I think, is about going on how to develop care delivery teams. And I think it's governance who's doing organizational communication, and the finance is working on data needed for negotiating value-based contracts. These are great discussion forums. We really need your input. So email any of us if you aren't on there, and we can get you with the login and information for it. Great. Well, I'm going to turn the time over to Cristal, and she can introduce our two guests. Cristal is a principal at Leavitt Partners. In this role, she oversees Leavitt Partners State Insight Practice Area. This helps clients understand the policy-related issues and risks. She has 15 years of experience really leading health and human services agencies, community health initiatives, and Medicaid and health delivery system reforms. There's no one better to be here. Formerly, she was the Deputy Governor of the State of Illinois, a former state Medicaid director in Region 5 of HHS, and a White House OMB analyst. So Cristal is really a gem, hasn't been with the firm too long, but is making a huge impact in bringing her public service mentality. Cristal, let me give the time over to you, and you can introduce Russ and Judy, and we'll move forward with the webinar.
All right, wonderful. Well, thank you, John, for that introduction, and good morning or afternoon to everybody who's joined. I'm really excited about the conversation today, and particularly excited about having Judy Moore and Russ Elbel joining us. So I will just take a couple of minutes to introduce them and then turn it right over to them for the presentation and the content for today. Judy Moore is an independent consultant with expertise in Medicaid, Medicare, long-term services and support, and other state and federal programs. She was a career federal senior executive and later 14 years at the George Washington University. She served as a founding commissioner on the Medicaid and Children's Health Payment and Access Commission, MACPAC, from 2009 to 2015. And along with other articles and research papers, she is co-author with David G. Smith of Medicaid Politics and Policy, a political history of the Medicaid program. I know she's got a lot of great information to share with us from her perspective as a senior consultant on accountable care organizations. And Russ Elbel is the Medicaid and CHIP Program Director at SelectHealth. He has healthcare leadership experience in a variety of roles, including quality improvement, case and disease management, fraud prevention and control, compliance, network management, and health promotion. Russ earned his Master's of Science in Public Health and Health Services Administration from the University of Utah. He serves as a board member at Valley Behavioral Health, is a founding member of the Utah Coalition, and a member of the Utah Medicaid ACO Alliance. Russ also served as the past chair for the Utah Medicaid Medical Care Advisory Committee. So we welcome both of these very impressive speakers, and at this time, I am happy to turn it over to Judy.
Thank you very much. As the Leavitt folks know, my computer is not cooperating very much today, so I'm going to be not seeing my slides as you see them, I hope. As Cristal has indicated in telling you a little bit about me, I'm a longtime Medicaid aficionado, but fairly new to ACOs, and I suspect that many of you have more expertise in the functioning of ACOs than I do. But I have learned a lot about Medicaid and the different states' activities in ACO development in the last couple of years as a Medicaid advisor to the National Association of ACOs, NAACOs. So I will be giving you kind of a bird's eye view of what is happening in various states and across the country, and that'll at least get us started and everybody on the same page. And if you can start, I don't know if you've got the Medicaid ACO and background and evolution slide up, but that's where I'm going to start. Most of you know quite well that Medicaid is administered by the states, and many, many policy decisions are made by state officials. And this is sort of the basic going in, and I want to remind you of how many differences there are between and among states, with many, many choices by administrators of the program, by legislatures, governors, and all of the other folks who want to have a hand in the policy of Medicaid and are overlooking the budget in Medicaid, which is so very large in so many places. There are many different cultures in state government and delivery systems, and all of that makes this a very difficult subject. There's lots of variability in ACOs and payment models as well, of course. There was a lot of early interest right after the enactment of ACA by states in an ACO type of model. That's when the Medicare work was getting underway, and that preceded, at least from the federal government, a push for states to move towards ACOs or other kinds of value-based purchasing. And in 2011 and 12, a good many states were interested in delivery system reform, and there was a big push from states as well as CMMI, the offer of waiver money from the federal government. It was a new idea. A lot of states had been involved in value-based purchasing work in a small or perhaps a larger way through Medicaid managed care. But states were intrigued with this idea of an ACO type model for Medicaid, and there was a lot of money available from the federal government through both the SIM program and the DISRIT program, and so Medicaid experiments and money was slower than Medicare, but by 2012 or so it was beginning to catch up a little bit. There was the ACO models have been modified over time, and I think there's been slower progress than people initially anticipated. But one thing is still unchanged in Medicaid, and that is the continuation of interest in Medicaid managed care and the continued expansion of Medicaid managed care. And if we can go to the next slide. So there are three models that I've kind of identified, and I've talked to a lot of people, and they agree with me that this is the right approach when you're thinking about ACOs or ACO-like entities in Medicaid. One of them is where the state actually contracts with ACOs to provide Medicaid services to beneficiaries who are eligible for Medicaid. This is a direct contracting, state to ACO, and Massachusetts, Minnesota, Oregon, Colorado are good examples of that. A second model is one in which the state actually requires MCOs to contract with ACOs, and there are sometimes there are all MCOs, or sometimes it's just a few MCOs that are contracting. And then the final is formal and informal MCO arrangements with ACOs to provide services. This is probably the largest number of ACO service delivery options in Medicaid. Their national numbers are incredibly hard to find, and frankly, I've seen some and I don't know that I trust them, but that's life. Go on to the next slide, please. There are some sophisticated and very significant ACO Medicaid models. These are in alphabetical order, and a couple are smaller than other ones, but they're basically states where there's a lot of state to ACO contracting. Massachusetts, Minnesota, Oregon, and Rhode Island. I don't have a lot of time, so I'm not going to go into a great deal of detail. At the end of my presentation, you'll find a couple of references to sources for further information. I would say that probably Massachusetts, Minnesota, and Oregon are the most sophisticated of the models that I have seen and that I am aware of. And they have a great deal of work going on in terms of social determinants of health measuring and requirements for ACOs to get involved in that, and rewards for states that do that. Rhode Island and Vermont are smaller states, so they don't have quite as many people involved, but they both have an extensive commitment to state ACO contracting. Next slide. I have listed on this slide other kind of important state ACO or ACO-like programs. Colorado is often would be put by some people in the category of significant state models that I was just talking about before. I have listed them in kind of the other important model list because they only do primary care, as many of you already know, and so it's not the full-blown ACO model that we know in Medicare and in a few other states. These other states all have significant ACO programs going on. In Iowa, for example, the managed care organizations are required to contract with ACOs in their area. Maine has a small pilot program, but it has brought some savings to Medicaid, and they're very committed to it. New Jersey also has a small pilot. New York has a huge DSRIP waiver, a lot of money there, and they've used it. They do a lot of MCO contracting with ACOs. They're a state that I think early on in 2010-11 thought they might get into ACOs in a big way, but kind of shifted gears. And most of their work now is MCOs, Medicaid managed care organizations, contracting with ACOs, but there's a lot of development of partnerships and a lot of interest in community-based services and social determinants work. And Utah, and my colleagues here know lots more about Utah than I do, but the state, Utah ACOs are more state defined than in some other places, and they don't necessarily match exactly the Medicare model, which some of the other ones do. It was one of the early ones, began in 2011, and it was described to me as the state's approach to expanding Medicare managed care programs into risk-based contracting. but it's a strong and ongoing program. Next slide. I've just listed here, in an interest of time, I won't go into too much detail, a bunch of the features that relate to the adoption of ACOs and the management and administration of ACO programs in states. They've really been adopted as part of in most cases, a larger value-based purchasing strategy. They are very often part of a waiver or a delivery system reform program that includes some considerable federal funding. This is not, always uniformly true. Minnesota, for example, and I believe Colorado, run their programs under a state plan amendment. So it's not always true, but it's usually true. It is these ACOs and ACO-like programs are driving data and financial infrastructure to a large degree, and the states are all very cognizant of the fact that they need to be concentrating on this, not just for ACOs, but for their whole program. There is a need for a commitment on the part of the state to considerable oversight and administrative monitoring if they go into an ACO or an ACO-like program, and that is sometimes easier for some. It's easier for some states than it is for others. And as I mentioned before, there is a focus on social determinants, measurement and monitoring and development in most of the leading ACO states. Next slide, please. There are a bunch of challenges to Medicaid providing services through ACOs, and I have listed some of those on this slide. Every state needs their own unique program. As we've discussed before, there are state delivery system characteristics and idiosyncrasies that are unique to each state and probably each region of the state, for that matter. There's a real need to mesh ACOs and MCOs in most states, because most states have some kind of managed care or value-based purchasing program in effect. And there are always growing pains and challenges when you're doing that. I already mentioned financing and data infrastructure, which is very lacking in some places and very sophisticated in others, but an issue in every single state. And the federal funding has been key to addressing those problems. I mentioned before the need for oversight and monitoring, and there are a number of states that have not had, in sort of traditionally, a strong state staff with the right kind of expertise for monitoring contracts, developing RFPs, quality expertise, and so forth. So there are a variety of skills that one needs to assure are available in state staff when going into ACOs. Social determinants of health is a great interest across the country, especially as Medicaid managed care goes more and more into LTSS services. And then finally, the last challenge is working with the federal government in order to access some of those funds. On the other hand, the federal government has had a lot of technical assistance available, and that's been, I think, very useful to states. Next slide. In terms of the future, I think the most important consideration in many places is how ACOs will fit or have fit or might fit with managed care, which predominates basically in care delivery for Medicaid. And I think that's going to continue regardless of with or without ACOs, basically. The question of oversight, valuation, monitoring, the costs and benefits of the program, states really need to review their decisions and consider and reconsider, if only because their legislatures are going to ask them every year. And while there are reports of savings with Medicaid ACO programs in half a dozen or more states, and some of them quite significant, it's hard to know if those savings can be replicated in another state given the unique circumstances in for example, Oregon, which has a global budget system. And then finally, the future of federal funding for delivery system reform and the federal waiver policy are very important. There's a new administration, there are new policies, and the SIM, the innovation models are likely tapering off. There was some talk about new funding under this program within CMMI and CMS, but I've talked to several people about that, and it doesn't seem to be on the front burner right now. As Cristal mentioned, the delivery system reform programs are probably going away. That has been huge money, billions in some states, and it has fueled and supported a lot of value-based purchasing strategies. So the question is whether those are really sustainable, as was the promise to the federal government in the beginning, or whether some of this work will go away when the federal funds are not there. My own personal view is that the leading states, the ones who are really in the business of working with ACOs, will continue in the future and expand and enhance and work very carefully to produce more risk-based programs if they don't have those yet, or expand them to other ACOs, because sometimes they have risk-based programs with some groups and not with others. And but my own personal view is that there probably won't be a lot of new state ACO programs in the sense of direct state contracting that's widespread. I think the biggest opportunity in the future for ACOs to contract for ACOs to serve Medicaid beneficiaries is going to be through contracts with Medicaid managed care organizations. So that's kind of my crystal ball gazing. I'd love to hear what anybody else might think on this subject too. Next slide. This is my last slide has some information where you can get some additional information. If those of you who are pretty well versed in Medicaid ACO work will know about the Center for Healthcare Strategies, which has fantastic resources, papers, all kinds of tools, quality information, blog notes, just a wealth of information on their website. And I have I frankly have learned most of what I know from them. NAACOs, my organization, has a little tab on their website about Medicaid ACOs. It will tell you a little bit more about some of the states that I've mentioned today. And I've got my own contact information there. If anybody has any questions, I'd be glad to talk to you further about this. And I think we're going to have some more questions at the end of our time, so I will be done at this point. Thank you.
Great, thank you, Judy. And I do just want to remind our participants that they can enter in questions in the Q&A box, and we will be taking audience questions after Russ's presentation. So I'm now pleased to turn it over to Russ.
Well, thank you, Cristal and Judy. Thanks for that fabulous overview of ACOs. And what I'd like to do is give you an overview of the work that we're doing here as one of the ACOs in Utah. And let me start by just giving an introduction to SelectHealth and Intermountain Healthcare. SelectHealth is, and we are a wholly owned subsidiary of Intermountain Healthcare. We're a insurer in the community. We cover over 800,000 members across all segments of the community, including commercial and government business. And many of you are probably more familiar with Intermountain Healthcare. Intermountain Healthcare is a fully integrated delivery system. Intermountain was formed in 1975, and just one interesting note to add here is that it was formed through a donation to the community from the LDS Church, who owned a number of hospitals in the community, donated those to the community and created a community board to begin to lead that. And the one requirement that Intermountain, that was put on Intermountain, is to continue to strive for and to become a model healthcare system. And that is our formal vision at Intermountain overall. Next slide, please. Utah moved to an ACO model in 2013, in which the majority of the Medicaid enrollment moved into Medicaid ACOs. And that's when we launched our Medicaid ACO as well. The ongoing objective for us has been to align incentives, and what we have is a shared accountability and a shared risk model where the healthcare premium is split, and the delivery system manages the overall risk for medical expense, and then the health plan manages overall risk for administrative expense. With that framework, the goal has really been, and the outcome has been, engagement and integration and innovation. The early wins in terms of engagement by both the delivery system and the health plan has really been a more collaborative and integrated approach. Some examples to share with you was an early design of what was called a comprehensive care clinic, which was designed to stabilize care for superutilizers and transition them to primary care. Many of those individuals didn't have primary care and don't have primary care, so getting them stabilized and into primary care is critical. And then a community care management program, which is a home visit program to assess the patient's medical and non-medical needs and stabilize their care. More recently, telehealth has been implemented, and then we've also implemented a program with community health workers, which is a joint project with the Association for Utah Community Health, which is the support organization for our local federally qualified health centers, the aim of which is really engaging patients and addressing their health needs, again, both medical and their non-medical health needs. And then another area of engagement is just continued alignment of incentives. We have put in place a physician payment program to improve quality and the patient experience and engage all providers in managing the total cost of care. And then in that value-based payment space, we've also implemented a number of care coordination payments. Those are aimed at really providing support to clinics to create the right infrastructure, the right wraparound services needed to care for our most vulnerable enrollees. And then as we look to the future, we really look even more closely at how it is we can become a model healthcare system to meet the needs of those most vulnerable enrollees. Next slide, please. And as ACOs overall think about their role in caring for the most vulnerable enrollees, it's helpful to ground that thinking back into the triple aim. I'm sure everyone is very familiar with the triple aim. One area it's useful to think back on, though, and is to recall what the authors put in place or brought forward in terms of the preconditions to be successful. And they termed those the inescapable design constraints that underlie effective accomplishment of the triple aim. The first is recognition of a population as a unit of concern. So in our case, it's Medicaid. We also serve in our risk model Medicare. And then the second design constraint that they said needs to be in place to be effective is an externally supplied policy constraint, such as a total budget limit. And in that case, for us, that's capitation. And then the existence of an integrator able to focus and coordinate services to help the population in all three dimensions of care. And that is what we see as our role, is an integrator. And the authors point out in the second quote that you see there, in crafting care, an effective integrator in one way or another will link healthcare organizations as well as public health and social service organizations whose missions overlap across the spectrum of delivery. And for us and for many ACOs today, Medicaid ACOs, the future success really is linked to being able to effectively integrate social services coordination into models of care and move further upstream and address the social determinants of health and ultimately improve the health of the populations that we serve. Next slide, please. So why is it important and critical really to be able to address the social determinants of health? I mean, the clear answer or straightforward answer is Medicaid disproportionately provides care for the highly vulnerable. So when we think about a Medicaid ACO's role, this is really where it comes into play. This is a study that was published in Health Affairs in 2012 that identified the characteristics of vulnerable populations. On the left, you can see the characteristics of the socially disadvantaged, and on the right, the characteristics of those that are the clinically vulnerable. In the center, we have the group that's termed the highly vulnerable. And often in this group, their social needs exacerbate their clinical needs and often prevent their clinical needs from being fully addressed. And sometimes those social needs are the actual drivers of their utilization, which is really the suggestion that we need a different model of care to care for this population. Next slide, please. So one of the areas that we are moving towards is addressing the social determinants of health. We have formed an alliance with Leavitt Partners, Intermountain Healthcare, and SelectHealth, and our community partners, termed the Utah Alliance for the Determinants of Health. It's a collaborative approach to addressing and achieving health equity in our communities. It's established to help manage a 3-year demonstration to improve healthcare costs and health and the care experience among our SelectHealth Medicaid members in select counties. The efforts are in collaboration with a number of other community partners that we have. The communities will really be thought of as workshops or playgrounds to create innovation and integrated approaches and aligned approaches to addressing the health and the social determinant needs to improve health equity overall. And then the vision is really to be innovative, be a model for positive change in these communities that can be scaled and replicated across Utah to our other communities that we serve, and hopefully be some opportunity for other communities outside of Utah to learn from us as well. Next slide. So the objectives for the demonstration: overall improved health equity, as I mentioned before, in 2 defined geographies. But one is, of course, implementing and testing models of care for the highly vulnerable. The other is improving access to physical and behavioral health and social services, reducing unnecessary ED visits that result in admissions, and then decreasing overall healthcare spending for the populations that we're looking at. Next slide, please. So as we look at this, one of the things just to point out is why SelectHealth Medicaid members versus other members. And some of this probably is pretty clear at this point, but Intermountain SelectHealth, of course, are at risk for the care in this population. And of course, as I mentioned earlier, many of the Medicaid members fall into this highly clinically vulnerable and socially disadvantaged populations. And then it really starts to make sense for this population related to social determinants of health when you consider that it's a state-run program. It affords many opportunities to align with partners, not only at the state level, but at the county level, and then at the city level as well. And then it's also an area where we have a number of community partners who already serve the Medicaid population. They have established efforts in place, and they have similar interests in addressing the social determinants of health. And that's really where we have significant opportunities to start to align in different geographies to improve so the social determinants of health and health overall. Next slide, please. So as we start to look at how we wanted to determine geographies, we first said that we had to have at least a minimum number of enrollees in a geography or a zip code area. And Utah is very broadly dispersed. Most of the enrollment is in what's considered the Wasatch Front and an urban area, and then other areas are considered rural areas. So we needed a minimum number, but we also needed, in terms of understanding where the best places may be, is other criteria, including the readiness of community partners to be involved in the initiative. So we used as criteria relationships with community partners that were in place in different communities. We also looked at, are there already efforts in the community to improve the community as a whole in terms of intergenerational poverty? And then where do we have existing collaborative efforts? Where do we have partners where we're significantly involved today, where we, again, have very, very good relationships where it would make sense to start to align and build and support those relationships? And then determining the geography also came down to being able to identify where do we have communities that have significant disparities, and what are the right, what criteria can we start to look at to understand those disparities? Next slide. So as we looked at that, as we started to develop criteria, we had a couple of sets of criteria that one considered highly weighted criteria, and another considered that we called moderatively weighted criteria. And you can see on the right, the highly weighted criteria were hospital readmission rates, disease categories, the percentage diagnosed with diabetes. We also looked at emergency department usage, as well as admissions from emergency department usage, and specifically focusing in on ambulatory care sensitive conditions, conditions that really could be treated in primary care if they were effectively treated, ambulance use for typical outpatient care, and then looking at those with disabilities, and then behavioral health as well. And then you can see secondary or moderately weighted criteria, and just to mention a few, opioid prescription use, substance use disorders, and then again looking at those with disabilities. And then we did have some data from our state partners on WIC recipients and average income and education level that we were able to fold into a criteria to start to look at different geographies. Next slide, please. That work was used to select 2 geographies, and we used that from a hotspotting standpoint. And we were able to identify 2 geographies where we had a significant enough number of enrollees in specific zip codes where it really made sense to start focusing our efforts. So this slide shows the different deciles of deprivation from greatest to least, and we looked for communities that were between deprivation of 1 to 4 deciles, and you can see in the red that that is the decile that would be the highest. And so the communities were selected based on population size and need, again, as well as a strong system of community collaboration that showed readiness for this type of innovative approach to addressing health equity. Next slide, please. So as we have now identified 2 communities, we've started to look more closely at interventions and models for intervention. And so on the left is just a conceptual view of the integration or alignment between physical, behavioral health, and social determinants. And the basic model on the right is really looking at a very similar model, as you may notice, to the Accountable Health Communities model that was put forward by CMS in 2015, I believe. But the basic model is really being able to improve organization of services both in the community with our community partners, but also internally to care for the highly vulnerable populations, systematically assessing and addressing social needs. So being able to use a screening tool that assesses social needs. And then from that screening tool, being able to identify those at high risk, both clinically and socially, and referring and navigating to community partners, and then aligning and integrating and supporting our community partners, especially in the areas of with those community partners who already address the social determinants of health, and where can we actually support them further in those efforts once we get someone through their doors. And then I think that one of the real powers of what we're doing is a collective impact approach. We have 2 local community steering committees made up of local government representatives, community partner stakeholders, as well as SelectHealth and Intermountain, to really start to help in some of the design and guide the interventions along the way in the local communities. So again, a very collective impact approach. And then finally, we'll be evaluating and looking to scale to other communities, as I have talked about earlier. So let me give you just a little preview into that model in action currently. We have a carved out behavioral health system in Utah. And one of the things that we do have, though, is a fantastic relationship with our community partners in behavioral health in the 2 communities that we're looking to implement in. And by that, I mean they have skin in the game. They contract with our hospitals for inpatient psychiatric admissions and with our integrated mental health clinics to improve access for individuals who have lower acuity behavioral health conditions and who may want to continue to obtain care by their primary care physician in the location they're already in. And we have started to begin our process of really collaboratively shaping an intervention with those behavioral health plans. One of the pieces we're looking at very closely is how do we share data to start to engage. The behavioral health plan has limited insight into who they need to reach out to for services. They don't have the surveillance tools to do that. Their tools today are limited to individuals who end up in the hospital, and it's too late. And so we're looking at how we can help them get upstream, and that's where we can help by sharing emergency department use for populations that have mental health conditions, and helping them see who they should reach out to, get them into the care that they need. And then one of the unique things about behavioral health organizations is that they have recognized decades ago the importance of addressing the social determinants of health. So our intervention here is really getting the right people through the door from a behavioral health standpoint, and then they have interventions already in place to help with housing, to help with financial services, and to help with employment services. But we need to help them get the right people through the door. So that's one example of starting to put that model into place. And as we look further down the road with that model, we hope that we can start to actually support them further with the work that they do in the area of social determinants of health, perhaps by supporting them to prop up their programs such as financial and employment services and other services such as housing. Next slide, please. So where do we see ourselves going in the future, and where do many Medicaid ACOs see themselves going? Well, to look more like a taco. So not the taco on the left, and I realize it is lunchtime for many, so that probably makes you hungry. But I hope that as ACOs, we're really hungry on the right side. This is becoming a total accountable care organization, which is a healthcare system where all physical health, behavioral health, long-term services and supports, and elements of public health and social services are integrated for targeted high-need populations. And again, this ties back into that triple aim integrator role. And for us as Intermountain Healthcare overall, as I mentioned in the beginning, our vision is to be a model healthcare system. And as we look at how we care for vulnerable populations, this is really how that vision starts to shape up. I appreciate the opportunity to present to the group, and I hope that what I've shared has been insightful and useful, and I'll turn it back to Cristal for questions and discussion.
All right, that's wonderful. I want to thank both Judy and Russ for their insightful presentations and being a part of this webinar to share their perspectives today. So I want to turn it over to, not turn it over, but want to move to audience questions. And we do have one, which is, how is data shared between the health plan and the providers or community partners? How do you actually measure improvements of patients?
And I know that question is for me, so I will jump right in. Yeah, so it's a really great question, and it's a piece we're working through right now with the behavioral health partners. So we have been sharing data for quite some time with our behavioral health partners, and the way we've been sharing it is through a Tableau data sharing platform where we share high-risk members who utilize the ED on a regular basis with them, sort of in the hope that they will engage the population, and they do that. What we've learned more recently by having them share with us the population that they are caring with and us matching up utilization data is maybe some new areas that we need to focus. So one is we can see from the data that we've looked at collectively that many of those most severely ill individuals that they care for don't have an attributed primary care physician. So when we think about how do we measure the impact of sharing data, one is can they help with their own population that they serve today, starting to help to get individuals engaged with primary care, because as I'm sure most of you know, those who have a severe mental illness have a shorter lifespan, and much of that has to do with the fact that they also have chronic conditions. The medications that are used for severe mental illness contribute to their chronic illness, and it's critical for them to have primary care. So that's one gap that can be closed. And then the other is providing them with timely data on emergency department admissions so that they can move more upstream to prevent future psychiatric admissions, but also so they can start to have care coordination discussions as soon as possible about visits that took place that didn't need to take place in an emergency department, but could have taken place elsewhere, or perhaps didn't need to take place at all because it may be related to their mental illness, and that piece may also be related to something from a social determinant standpoint, such as isolation. So I hope that's helpful in answering the question. I mean, that's part of how we see starting to share data as we go forward and really engage our community partners in improvement.
Great, thank you, Russ. Another question is about HIPAA, and how do you address HIPAA restrictions and HIPAA concerns when you're working with community partners in that data sharing?
Well, in the example that I gave, our community partner is what's called a prepaid mental health plan. So they have, for the Medicaid population, they have full responsibility for the care of every individual. So they're a covered entity. There's not a HIPAA issue in place. Where there is an issue that we need to be and are very careful of which is the 42 CFR protections, which are around sharing treatment information on substance use treatment. So we steer away from that, and where we steer to is just the mental health condition that the individual has, and that is just a proxy to individuals who typically will have not only a severe mental illness or mental health condition, but most individuals who fall into that category also have a substance use disorder. So that proxy helps the mental health plan start to engage. And by using that proxy, we stay out of the world of a legal issue with 42 CFR.
Got it. Judy, did you have anything to add?
No, I think that there are a number of states that have addressed this issue, and the CHCS materials, while there is not one, I don't believe, that directly addresses this, does touch on it, and it gives some examples of state activities. So I think people might want to take a look at that. I'm sorry, I can't be more specific about what they have to offer, but I know they've covered this in one or more of their papers or their webinars. Okay,
great, thank you. So I know another question that often comes up in my conversations with providers and other organizations is about the startup costs for developing a Medicaid ACO. And if you might be able to share, Russ, from your organization's experience, or Judy from your research, what should organizations expect if they are looking to participate in an ACO model or become a Medicaid ACO, understanding that that likely differs depending on you know, what finance and data infrastructure already exists versus might have to be built?
Yeah, I have never seen a comparison of this group or that group, or with real dollar amounts involved. I've seen papers related to design considerations and the kinds of things one has to consider, but I've never seen very many specifics. So I don't know that Russ may have added up his costs. So I think that's a tough question, and I think it's one of a number of issues that one has to face when looking at starting up a Medicaid ACO relationship of one type or another.
Yeah, I'll just build on that and say that, yeah, we have not ever put together what did it cost us. I would say that where you have momentum, then you can have economies of scale and you can reduce startup costs. So the example there is, if you're already a healthcare system that has providers and you have a health plan, you have all the components to move into the world of being a Medicaid ACO. And then there are, of course, significant startup costs to shaping yourself to becoming a Medicaid ACO. If you do not play in the playground of government programs today, that is a whole new world. But also the other piece that you have to be committed to as a healthcare system, if you have those components in place already, is committed to the population, and recognizing that you may start out with a population that is small and you have to grow that population. And I think that is one of the significant challenges for many groups, even when they're an integrated system where they have a health plan and providers and hospitals, is the recognition that it takes a while to get to a critical mass where it makes financial sense for you to be in that space. So I know that probably doesn't address the overall question about startup costs, but much of it has to do with where you want to be as an organization in your particular community, in serving the community.
Great, thank you. So Russ, both you and Judy talked about one of the things that sets the ACO model apart is this focus on social determinants of health. Even though states are increasingly starting to build SDOH concepts into their more traditional managed care programs as well. But I'm wondering, what have you seen as far as the readiness of the non-medical community to become partners in the ACO model? And what has been the biggest challenge to developing those types of relationships with organizations that, you know, that aren't necessarily used to or have a lot of experience operating in the healthcare space?
Russ can probably answer that quite specifically. Let me give a general answer first, which is that in all the folks I have spoken to, both state folks and ACO folks, both health providers and community providers, they all mention a couple of things. One is the lexicon is different. The words are different between the healthcare providers and the community providers of social services of one sort or another. They don't necessarily talk the same language. So there's a big investment in getting together to understand one another when you go into an ACO that wants to look at population health and partner with the community for social type services. So and there are some states with considerable federal money who have tackled that head on. Massachusetts and New York come to mind, and Minnesota as well. And it is not a small undertaking. In addition, there are all the other more common sense kinds of things that you would think of data sharing and systems and financial arrangements and just plain old contracting language and that sort of thing. But I think everybody that I've talked to about this always mentions the communications problem as an entry-level issue.
Yeah, and I'll just add to that with, I think that particularly as you start to work with partners who are really working completely in the area of non-medical social service needs, it's really trying to integrate and align interests and each party really starting to understand how do we get the right handoffs and navigation and aligned interests so that we're really meeting the needs of the individual holistically. And so, for example, if we have individuals that we know have social service needs and we can navigate them to the right partner in the community, what we need that partner to do is, of course, address their social service needs, but we also need that partner to understand enough about our system and the clinical needs. When they see a clinical need, they know exactly how to give the handoff back to us. And that's the type of the integration and alignment that we're looking to create in our demonstration. And I'll mention that I had a fabulous opportunity to visit with some of the CCOs in Oregon several years ago, and that was the type of integration and alignment that I saw in an example in the community, and that's really what we're aiming for.
Okay, I'm looking to see if there are any other questions from the audience. I am not seeing any. Let me see. So I'm wondering, again, so Russ, please correct me if I'm mistaken, but in the demonstration, the model that you are participating with is one in which you've created an ACO that is contracting directly with the state. And Judy mentioned that there are also models where you know, the ACO contracts with or through an MCO that then has the direct relationship with the state. I'm wondering from either one of you, have you seen any correlation between the type of ACO model and the success of the ACO? Is there any experience that indicates that ACOs might have better experience if they, kind of have that intermediary partner, or whether they contract directly with the state?
I have not seen anything like that. I think it's very dependent upon the culture of the state, the delivery systems used in the state, the experience, the past experience of the state with Medicaid managed care and managed care organizations. Just a myriad of different problems and experiences that would be brought to bear on that.
I'll just second that. I agree. I haven't seen, as I've looked at different models, any one model that works better than another. It really is how a state executes upon the model that they put in place.
Okay, and I see that I got so into this conversation I lost track of time. So for our last minute, I would like to turn it back over to John Pullman, and Judy and Russ, I want to thank you so much for an engaging conversation.
Thank you.
Bye. Glad to be here.
Great. I'll just echo that. Thank you. Judy, what an expert you are. And Russ, what fascinating things you're doing in Utah, and grateful for your leadership. Cristal, thanks for your moderating and putting this all together. An audio recording of this conference call will be available. Look for it in our weekly news summary. Remember to save the date, October 23rd in DC, and join our work group meetings. If you have any questions about the ACLC or have any additional questions you want to submit to panelists, to Judy and Russ or Cristal, you can just email the members at accountablecarelc.org or others. Happy to address those. Thanks for joining us. Hope you found our presentation worthwhile, and we'll see you all soon.
Thanks.
Thank you.